Hi, this is Junaid again, back with another lecture on acute ischemic stroke 2019 guidelines. In this lecture, we're going to continue from the previous one and discuss more of the general supportive care for acute ischemic stroke patients when they're hospitalized inpatient. So last lecture, we discussed about stroke units, head positioning, supplemental oxygen, blood pressure, temperature, and glucose. And in this particular one, we're going to discuss dysphagia, nutrition, DVT prophylaxis, depression screening, other, and rehab. So dysphagia screening is considered one of the very important things that we do in the stroke units. And generally speaking, believe it or not, the level of evidence is C. That means that there is no good level of evidence. But if you look at the class of recommendation, it is 1. So it is very highly recommended that every stroke patient do get dysphagia screening. And then secondly, not just a dysphagia screening that can be done by any professional or healthcare provider, as pointed out in number 3. Again, if you look at the level of evidence is C, but the class of recommendation is actually 2A. It means that it's recommended to actually do that. However, additional procedures like video fluoroscopy to actually see how the swallowing goes, or fee study, which is a way to actually do endoscopic evaluations to verify presence and absence of aspiration, should also be considered. If you are doing evaluation for swallowing, what kind of procedure you need to do, for example, video fluoroscopy versus fees, there's no general recommendations which one to choose. It is up to the provider to actually choose accordingly. And the oral hygiene protocols generally is a very good idea. Being a neurointensivist in the ICU, we know the benefits of it, how it decreases pneumonia. And if it is applied in stroke units, it's extremely helpful for the patient to reduce the risk of aspiration pneumonia in these patients. Nutrition-wise, it is important that we start nutrition within the first 7 days. The longer you go forward without it, it is actually detrimental to the patient. The level of evidence is B, but the class of recommendation is 1. And what we have seen is that some of these patients are obtunded and therefore they take out the NG tube, or because of multiple reasons, including evolution of a stroke or cardiac problems or another infection, sometimes nutrition continues to get delayed. It is extremely important for the recovery of patient that the nutrition should be within the first 7 days, potentially sooner. And you should use nasogastric tube as much as possible. And if there is an inability to swallow, they say that about 2 to 3 weeks. But if you see the progression that is not going to be good, you may consider earlier PEG tube placement as well. Nutritional supplements, including protein, should be considered. I do it regularly. I get a nutrition assessment from a nutrition consultant practically all my stroke patients. And one of the reasons is that we forget that they can have protein malnourishment. And then also importantly, stroke is a bruise on the brain. It should actually be like a trauma patient comes with a bruise. We need to basically make sure that there is enough nutrition, both from macronutrients and micronutrients, to support recovery and rehabilitation. DVT prophylaxis is one of those things that is always a big problem, and always people are concerned about it. First of all, mechanical DVT prophylaxis, which is intermittent pneumatic compression devices, period. You should do it. Level of evidence is B, but class of recommendation is 1. Now, if you are going to use a prophylactic DVT prophylaxis with pharmacological, then if you look at the level of evidence, it's actually A. That means that it can be useful, but this class of recommendation is only 2B. And the reason behind it is that there is a slight increase in the intracranial hemorrhage, and people may have argued that this is possibly secondary to the DVT prophylaxis. But if you look at the whole big literature of DVTs, especially in our patients of stroke, where you are actually having problems with immobility, then DVT prophylaxis makes much more sense. And if you have to choose one, then low molecular heparin weight with Lovenox once a day, not a therapeutic dose, prophylactic doses should be considered. Over here, it suggests that the benefit is uncertain, and I agree. If you look at the studies, there are mixed messages. However, it is once a day, and it technically is easier for the patient and the family members if they go home and continues to be immobile, or if they're in a nursing home or a rehab unit. So overall, it's just not about the data of how good it is also how convenient it is. So therefore, preferably I use Lovenox once a day dosing for these patients. Elastic compression devices is not useful, clearly, because those are for dehydration or patients who have orthostatic hypotension. Depression screening is actually very important to actually do on every patient. We see a lot of depression going in, and then depression by definition needs to be about 3 months. However, when you have an initial depression screen done and then there could be a one evaluation done at a later date, this is extremely useful for our patients. There would be objective evidence of depression. I generally do not start antidepressants within the hospital course. And one of the reasons is that my preference has always been to get these patients out to rehab as soon as possible. At that point in time, when you're looking at that as an objective, it's too small of a window to actually really say that, the patient actually has depression. Because the first 3 days there's swelling going on, the patient actually gets worse, and by day 5, they're actually going back. And at that point in time, you really want to make sure that, you're starting a medication that's actually going to help the patient. The real example that I personally use is patients with PEG tube. And the idea is that if there's a FLAIR trial which has a minimal sort of improvement on the patient's mood, however, at the end of the day, if there is one of these things in which you're really trying to figure out if you're really going to need the PEG tube or anything, and it's depression, non-cooperative behavior is one of the issues, then you may consider inpatient. But generally, I do it outpatient for my patients, but I do screening on all patients inpatient. Regular skin assessments needs to be done. Clearly, this is not just something that for stroke patients, for any patient in the hospital, and then clearly minimize the risk of decubitus ulcers. If patients are struggling with decision making, it is important that palliative care services and resources can be appropriately used. The problem really here is that they act as an impartial in-between resource between you as a providing physician who has a bias to treat. You may have given TPA, mechanical thrombectomy, however, and you are so invested in that patient's improvement that sometimes we as physicians lose sight. And they are really good at providing, a consultation and resources. So some places do have it as a proper consultation, this is not the recommendation, but palliative resources and discussions need to be done in each patient, either by you or a palliative care consult, however that may be, if the stroke is something that's debilitating enough that the patient would not want to live with those kind of disabilities. Do not use prophylactic antibiotics. There's no point. This is not an infection. This is a stroke. And for God's sakes, do not put indwelling catheters. It significantly increases the risk of UTI. At my own neuro ICU, I decreased the UTI from 25 per year to 0. And that was actually very, very important. That these are the things that we actually measure now very appropriately, especially in ICU settings and hospital settings. So please don't use them. Rehab is the key. At the end of the day, if the patient is going to improve, it's not because, to be honest with you, I gave TPA and mechanical thrombectomy, thank God. But at the end of the day, rehab and early rehab is the key for patient successful outcome. Level of evidence A, class of recommendation 1. The intensity and all those can actually be depending on the patient or the person and how fast and how much they can do. My preference has always been, because if you look at the real guidelines, the sniff is 45 minutes per day and the rehab is 3 hours per day. So the intensity really depends on how much the patient can do, and that actually determines if the patient is going to go to a rehab center or a sniff. So preferences that I actually provide them with encouragement, ask the family to take part in it, and make sure that if the patient is slightly on the edge of not going to rehab, give them a day or two to improve so that they can be eligible for rehab. So those are the kind of things you can do as a physician to make sure, or a provider, to make sure that your patient gets the best care. Formal assessment is needed, period. There's no ifs, ands, or buts about it. That actually determines not just a future rehab need, B, palliation if need be, and C, have objective evidence of improvement. So clearly for rehab, we need to actually make sure there is formal assessments done. The functional assessment by clinician, there are physiatrists who do that. And those physiatrists, again, are extremely important because they have a longitudinal view as well. And they are able to educate not just the patient and the family about what to expect. They actually become very useful. And in my opinion, the physiatrists I work with are amazing people. And not only that, they have come back with questions down the line to me so that by the time the patient comes to the stroke unit that could have been long gone or forgotten or whatever, they were able to help me take care of my patient in the interim between the hospital and the clinic, and they have been very useful. So my personal recommendation, which is concurrent with class of recommendation here, is to use them as much as you can. Effectiveness of fluoxetine, as I said, this is the FLAIR trial. It is not really well established. As I said, in some certain cases, I start them within the inpatient unit, but within the rehab unit, I have actually asked, when I'm signing out to the rehab physician, I always tell them, hey, this patient is probably having a little bit of depressions. Can you please keep an eye on it and may be eligible for fluoxetine, etc. There is no real reason to do high dose very early rehabilitation. You should consider early rehabilitation as within 72 hours, but not even high dose. Appropriate to the patient's expectation is something we should consider. Again, I'm very grateful for your time. Thank you very much. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.